onset sepsis in our setup vis-a-vis UK or US. So we know that that part of the world, group B streptococcus remains the most common organism, and intrapartum prophylaxis, what you are talking about in the mother, that also related to the GBS. So all these risk factor calculators, they are based on the incidence of GBS sepsis in these babies. So, and we don't have that. So we have very few units. I was actually looking at some of the good units. Only 1 or 2 units in the country where they regularly see GBS. At our hospital in Gangana, we have around 1200 admissions, and we see maybe 1 GBS in 2 years. So that is that low incidence of GBS. So that means whatever is being said for these calculators, which are meant for those countries or those units which see GBS as the most predominant organism in the early onset sepsis. In our study, in Delhi study, the trials have shown very clearly there is no distinction between early onset and late onset sepsis. It's all gram-negative bacilli. So in this, if you look at asymptomatic babies, more than 35 weeks, and look at these calculators, whether they make us wiser in deciding whether there is infection or there is probability of infection or not, we are no wiser. So that is why I come again to the NNF guidelines, which are very clearly saying that there is no use of using early onset sepsis calculators, which is developed in high income countries for these babies who are asymptomatic and beyond 35 weeks with risk factors. So at our center, we are not using any of these calculators, and we are very happy to say that if you see, first of all, you remember it's an asymptomatic baby. So you have to look at a very high sensitivity for these calculators. If you look at the sensitivity, pool sensitivity is only 0.49, 50%. Just like flipping a coin, it may come this side or that side. You are as wiser as you were before. And even the specificity is not very high, it's 87%. So we are saying that all these calculators, we should not be using it. We are not using it at our center. And we are very happy with the NNF clinical guidelines, which are saying red or yellow, which makes us at least restrictive. Because even if we come to the stewardship program, the biggest chunk of babies who are receiving unnecessary antibiotics are beyond 37 weeks babies who are with some risk factor. So if we restrict that, major work is done.
So thank you for the very clear message, Dr. Pankaj. We have talked a little bit about sepsis screen, CRP, and procalcitonin, but now let's get into a little more detail. So Dr. Pradeep, can CRP and procalcitonin be used reliably in the first few hours or days of life for early onset sepsis?
Okay, these two biomarkers are very often used in all NICUs to diagnose, particularly to diagnose. That is the word I would say for sepsis. But for early onset sepsis, you know the basic biology or biochemistry of these two tests. CRP, coming to the first CRP, it actually rises up 10 to 12 hours after the initiation of infection. So it's not a good marker for early diagnosis of sepsis. That is first. And the peak comes at around 24 hours. So if you are doing beyond 24 hours, then it may give some clues that there is sepsis. And studies have shown that people have done beyond 18 hours, the sensitivity is hardly 64%. Okay. So, but however, measuring serial CRP, that is important. If suppose you have done a CRP at 12 hours or so, or before 24 hours, you have to measure it serially. And if it is rising, then it gives you some clue. But if the serial value of CRP is negative, okay, then it is, you are almost ruling out sepsis. That is more important to rule out sepsis rather than diagnosing or to think about sepsis. Coming to the procalcitonin, again this is a biomarker, but it rises very rapidly, but it rises within 2 to 4 hours of initiation of sepsis. So we can think it's a very good marker because early diagnosis of sepsis. But there are some pitfalls in that also, because in healthy newborn also it increases in the first 48 hours to 72 hours, and it may go up to 20 nanogram. So because the cutoff value is 2, we take usually 0.5 to 2 more maybe probable sepsis. So this is the pitfall. It may normally rise. Also, it may rise due to different other conditions rather than sepsis. Okay. So these are the things. But serial measurement again, it would help in ruling out sepsis and your antibiotic stimulus. Okay. Then to summarize, both markers are more reliable after 24 hours of infection in early onset sepsis in particular. Elevation of one of them, you should not go think if the clinical scenarios or clinically it is you are not seeing that baby is looking to be sick, then you should not take that it is just sepsis is there, these tests are positive. Serial measurement are more reliable other than a single measurement, better in deciding stopping of antibiotics in early onset sepsis rather than initiation of sepsis.
We will have to move on because we are really running short of time.
Basically correlate with the clinical.
Yes. So we have understood some of the pitfalls of these two investigations. So Dr. Ashok, are there any promising new biomarkers that can help with early onset sepsis? Can you just list them for us because we don't have the time to go into details?
Yes, sir. So for the EONS, we have some new biomarkers. First is the pre-sepsin, and it is a cleavage product from the CD40, and this is proved in the recent meta-analysis which is published in 2022, and which showed the pooled sensitivity and specificity were 93% and 91% for EONS respectively. Then we have progranulin, which has a sensitivity of 93%.
Yeah, if you can just list them off because you have written on the others.
Then we have serum amyloid A protein, mannose binding lactin, and then the interleukins like 6 and 8.
Yeah. So, just like we had some scores for early onset sepsis, the question is, are there some similar scores for late onset sepsis? Dr. Pradeep, can I ask you again, are there any scores validated for late onset sepsis in India or developing countries?
Yes,
and again, very briefly.
It's a validated score is available for India. And the research was in PGI, taking 16 clinical parameters, out of which they found out these 6 to be more showing that sepsis is there. The likelihood ratio was more than 1.4. So these 6 parameters were taken and they were scored 1.4 for 1. So they have given a score with some research parameters. We are not going into. Again, it was validated in 2008 from PGI itself. Sir was the investigator also, one of the investigators. So we have a score, validated score for India.
Yeah, but of course we need a lot more research in this area. We don't have enough data. This is one sort of flash in the pan. Okay, so we have said the CRP procalcitonin have some problems with early onset sepsis, but what about late onset sepsis? Are they good enough for late onset sepsis? So, Dr. Ashok, what is the role of CRP and procalcitonin in late onset sepsis? And can you tell us how they perform individually, in comparison to each other, and in combination with each other?
So CRP it starts rising as sir said that by 8 to 10 hours, peaks at 48 to 72 hours. So we should know that the CRP has a poor positive predictive value, but it has a good negative predictive value. That the serial CRP, if we do one CRP at now after 24 hours a second, and it is negative, then it just rules out the sepsis and the cutoff remains more than 10 million per liter. And procalcitonin starts rising by 2 hours, peaks by 12 to 24 hours. It performs better than CRP. And it has a sensitivity of 90% and specificity of 88% with a cutoff 0.5 nanogram per ml. And there was one in 2018, the meta-analysis by Ruan et al. It says that procalcitonin do better than CRP, but procalcitonin and CRP, if we take together, then it has a sensitivity of 91% and specificity of 89%. Pre-sepsin also holds good in this.
Yeah, so this is, there are a few meta-analyses which have actually done head-to-head comparisons of CRP versus procal and what happens when you combine CRP and procal, and this is one of those meta-analyses, recent ones, which actually shows that if you take the results of both, so that means if you take that any one of them being positive would be considered positive, then it has a sensitivity of 91%. And if you take that both being negative would be considered a negative test, then it has a specificity of 89%, which is pretty good actually. A big advancement on either of them alone. So again, now similarly, are there any promising new biomarkers for late onset sepsis? We talked about early onset sepsis, and Dr. Prince, can you just again list them out without going into details? Because
yes, sir. So first of all, I want to say that we have lots of biomarkers which are promising biomarkers that where researchers going on, some have some advantages and some have some disadvantages, but still from decades they are searching for an ideal biomarker for sepsis. In the cytokines we have interleukin 6, interleukin 8, ratio of IL-6, IL-10, so they have good sensitivity and specificity, but yes, they have advantage that they rise early and they fall early, but yes, the availability, the cost, these are the factors. There are other biomarkers like serum amyloid A, presepsin, Estrem, and neutrophil CD64. So all these are promising biomarkers, but yes, we are still away from our ideal biomarkers.
So, looking at all the data so far, the one that will probably make the mark is probably presepsin. That seems to be the one that has maximum literature now, and all the meta-analysis seem to show that it's performing very well. We were going to take up one question about the common differential diagnosis of sepsis, but I think I'll skip that, Dr. Prince, that was meant for you, because that is something that we often talk about in rounds, and it's all there in the books. So we'll skip that and we'll go to another very important question, and that is, quite often if you have a sick baby, you have to take a decision, you're not sure whether it's sepsis or not, and inborn errors of metabolism often enter into a discussion about that baby. So what are the clues that can tell us that this is probably an inborn error of metabolism and this is probably not sepsis, and we should not be wasting our time running behind sepsis and losing precious time? So what are those clues, Dr. Pankaj?
I will say that let us divide this question into two halves. One is that a baby who is a term baby, he was breastfeeding well, he has gone home, he has come back to you on 3, 4, 5, 6 days with some symptoms. So there is no obvious disruptor in this baby. So baby will get sick out 2, 3 days without disruptor of sepsis. We should not think only of sepsis. We should think beyond that also, and there IM gets a very big role. And we will need to do tests. Fast progression of disease is another clue which you can get. Babies may go into shock, seizures, very fast running encephalopathy, renal failure, hepatic failure, cataract. So something which is very fast progression also gives you a clue of IM. Metabolic acidosis, which is especially high in iron gap, hypoglycemia, pancytopenias and coagulopathy, which gives you an idea that it can be something more than that. Also, the second subset, any baby who is admitted with culture positive sepsis in a term baby in our unit, we will also investigate for IM, because IM can be an underlying risk factor of sepsis in any of the baby who is with you, especially term babies. Preterm babies, HAI is the biggest factor. So investigating all of them also for galactosemias and all.
So are there any particular IMs which especially mimic sepsis more than others?
I will say from my experience, I have seen galactosemia presenting with gram-negative sepsis. We have diagnosed 2 babies who are presenting with culture-positive sepsis, and only investigation of GAD showed that they had galactosemia also. At that point of time, they don't even have hypoglycemia. So this is routine screening which is picked up. Tyrosinemia for hepatic failures. We have seen a number of maple syrup urine disease in our setup, presenting with encephalopathy and which suspected from sepsis from outside, multiple antibiotics, no response, coming to you diagnosed maple syrup. Metabolic acidosis, we are diagnosed with methylmalonic acidemia, propionic acidemia, seizure disorder, biotinidase deficiency, encephalopathy, urocycle disorders. Being a center where everything is being done, we have diagnosed so many of inborn errors, so that is why we have come to this conclusion that even if it is a culture positive sepsis, must rule out IM underlying. But if there is nothing else, everything is coming negative, definitely IM is on play.
Yeah. So if you are not getting markers of sepsis, don't go on giving more and more courses of antibiotics. So that's one problem that often happens. And as you rightly said, especially in a term infant without risk factors, even if the baby has sepsis, you must have IM. So galactosemia, typical. Okay, there are many other mimics of sepsis, like for example, congenital heart diseases. So, Dr. Ashok, I want to ask you this question. So, what are the clues that sick baby is suspecting to be sepsis? What are the clues that it could actually be a heart disease?
So, sir, whenever a sick baby comes to us, it is not always sepsis. We should always think out of the box. So, the points favoring a congenital heart disease are silent tachypnea in the baby, differential pulses in the upper limb and lower limb, differential BP in the upper limb and lower limb, murmur on auscultation, hepatomegaly, and disproportionate cyanosis. And then we do the sepsis screen, then it's negative, and on the chest X-ray we can see cardiomegaly or some patch of pneumonia. And CRP and procalcitonin also difficult to interpret while the babies are also on PG.
Yeah. So, PG1 is sort of pro-inflammatory, so it tends to raise these markers. Remember that, all the NSAIDs and prosins that we take are prostaglandins. So this is a thing to be kept in mind, that just because it is raised doesn't mean that it is sepsis. These are non-specific. So thank you for highlighting these points. So one condition that mimics sepsis, late onset sepsis, second or third week, is necrotizing enterocolitis, and it really creates confusion at times. And Dr. Pradeep, what are the clues that the patient actually has neck and does not just have a late onset sepsis? Could you just highlight those?
Yeah, both neck and late onset sepsis, they are usually present with systemic symptoms also. So it is difficult to differentiate. But in NEC, we get the clues from epileptocentric symptoms. Those are more, and along with thrombocytopenia and hyponatremia, acidosis, these are the triad, so-called triads for NEC. And along with that, two of the three rules that commonly followed, it is nematosis intestinalis in X-ray or ultrasound, persistent platelet consumption due to necrosis of the guts, and postmenstrual age, particularly this is the age when the NEC occurs. So the age is also favoring, so diagnosis can have NEC diagnosis in your mind. And there are the few factors nowadays. There's a come out factor 13 and all these. They are more prominent in NEC and to rule out sepsis.
So of course, the baby has not been exclusively a human being effect, so that becomes a. Okay, the last question that we need. We do not usually have investigations to look for viral infections, but all of us have this feeling that a lot of viral infections probably occur in neonates. And Dr. Pankaj, I will want you to highlight on this, that what are the clues that it's a viral infection and not a bacterial sepsis, so that we don't unnecessarily give antibiotics to such people?
First of all, you must remember that newborns hardly cough with bacterial infections. So if a newborn is coming to you with cough, you should always think viral first. Cough, running nose in a newborn, more tachypnea than, and the history of similar history in the family gives you a clue that there is something viral. Thanks to COVID, now we are thinking about viral many more babies than we were thinking before COVID. You get an X-ray, radiology looks very bad, but all the cultures, all the parameters are coming in negative. So I will say that we will diagnose viral infections only if we suspect them. Now respiratory biofilm is available.